told you guys I'm like Mrs. Magoo, right? If something weird or strange happens, it happens to me. And we'll look at your grades, sorry, on the next break. Okay. Okay, so got a little distracted by the time I got done. Let me just look through and get in my brain what we're going to be doing. So we need to talk about healing, right? Okay, we need to talk about healing and all the different processes that happen on a molecular basis with healing, okay? And healing happens how often in our bodies? All the time, right? All the time. And this was something, you know, once again, going back to that mentor that I used to look up to, that I never put together. Think about capillaries. How thick are capillaries? They're one cell thick. So guess what they're constantly doing? Breaking, right? Clotting, repairing, regenerating. Okay, you get stung by a bee, you have 2 little boys at home that beat you up. Okay, you're constantly going through this healing process. So healing is going to have a similar series of steps of repair. Okay, so we're kind of giving you like a composite view of what healing is, but it's pretty applicable to several different disease processes that can happen in the body. Okay. Skin, and those little, I've kind of imparted all those little segments of wit, which I thought we would have time to do, and we don't. So I would recommend you to watch the movie Wit when you get a chance with Emma Thompson. It's also on Broadway right now with the redhead from Sex and the City.
Cynthia Nixon.
Thank you, Cynthia Nixon. And she was spectacular. I was kind of surprised because she always seemed a little flaky to me on the show. She was spectacular. So if you get a chance, watch that movie. I think it's really a good movie for healthcare providers. Kind of keeps some things in perspective. Okay, so primary healing, healing by first intention. This is when the edges are close as opposed to secondary where the edges are what? Not close, right? So secondary would most likely either not heal appropriately or need sutures, okay? So, but primary healing, I'm going to walk you kind of through the steps, okay? So the first thing when you have some sort of damage would be a clot. And if the clot is exposed, okay, you would have a scab form on top of it, right? That scab is going to stay in place until the skin is healed enough to be efficient at being exposed again, okay? So a clot is going to happen by the deposition of what? What are the little fibers that are in the blood? Fibrinogen is going to turn into fibrin. Remember that step? And I can't get rid of this now. Oh, we don't need to really zoom in. So we've got fibrinogen turns into fibrin. Now, why do we have this happen? Do we want all the fibrin fibers just floating around free clotting everywhere? That sounded so funny. No, right? We want them to be specific to an area that's been damaged. So we store fibrin as an inactive form called fibrinogen. We have enzymes that'll facilitate the change from fibrinogen into fibrin. That'll begin that clotting process. We also have little chunks called what? Which help with clotting. Platelets, right? So platelets will help that as well. And there's a whole clotting cascade, which is a nightmare, which we're not going to really get into, of series of steps of enzymes that begin that process and end up ultimately in fibrinogen turning into fibrin, okay? So inflammatory cells move in. What are those fellows going to do? Inflammatory cells in general, they're going to, it's not a trick question. Cause inflammation, which will fight off any of those infections. Okay, try to deal with any infections. And then after the infection or the infectious agents have been taken care of and killed or destroyed, then phagocytes will move in, generally in the form of macrophages, and eat up all of that dead material, that pus, you know, all of those byproducts of the killing of those infectious agents, okay? Now, so phagocytes, and phagocytes is a generalized term for macrophages because there's different types of macrophages, okay? So I can kind of use those interchangeably, even though it's not totally appropriate. So those phagocytes or the macrophages come in, and they're almost, the picture that comes to mind is those phagocytes or those macrophages have a little brother, and that little brother is going to be a fibroblast. And that fibroblast is a little cell that kind of trails right behind those macrophages or those phagocytes. And what they do is the macrophages sort of eat up the junk, And then the fibroblasts start depositing collagen fibers. So we start to do what? Clear out the junk and create fresh new tissue. Okay, so fibroblasts kind of follow behind those phagocytes or those macrophages. Okay. Now, as that tissue structure, those fibers start to be deposited, they'll also create, remember, extracellular matrix? It's the junk that's going to hold the fibers in the cells. We create new extracellular matrix as well from those fibroblasts, okay? So there's the fibers, there's that extracellular matrix, okay? Where's I going with this? Oh, we also have to reestablish blood supply. If you damage an area enough that you're damaging all the tissues, you're going to damage the blood supply to it, okay? This is for tissue that has blood supply though, right? Okay, we're going to talk about different tissues and how they heal or they don't heal. So we're talking about tissues that heal and that have a blood supply, okay? They'll reestablish that extracellular matrix and the fibers, and they'll undergo what's called revascularization or angiogenesis, right? Genesis is the creation of, angio is blood vessels. They're interchangeable words, really, okay? So you start to develop these blood vessels in that tissue, okay? And that is called granulation tissue. Proud flesh, okay, is granulation tissue that hasn't completed the healing process, okay? So, and then reepithelialization will happen. So in areas that have epithelium, which is going to be covering and line, are you with me with epithelium? Did you guys review the tissue lectures? Does that ring a bell? Epithelium is going to be closely packed cells that will cover and line structures of the body. We have epithelium on our skin. That's a big one. We have epithelium inside our mouth. We have epithelium all the way down the GI tract, okay? So epithelium, if that is damaged, so if there's been some sort of tissue surface damage, a cut, obviously, an ulceration in the stomach, it's going to, in order to truly heal, need to rebuild that epithelium. Because what is the epithelium basically doing? What is my epithelium doing here? Do I have bacteria on my fingers? Sure do. Okay, yeah. Well, I washed my hands. I'm just saying there's bacteria everywhere. Oh no, I'm a big hand washer. As a matter of fact, I caught somebody earlier today when you guys weren't here not wash their hands in the bathroom.
What'd you do?
I should say something is what I should do. No. No, I wouldn't. But I think, ew, like, I don't know, big hand washer. But still, I mean, bacteria, you know, bacteria.
Problem by not addressing it.
That's right. I should put a sign up in the bathroom.
Putting
That's
that
what I
on your
should do.
evaluation.
Contributes to the spread of disease processing. Okay, so, but my point is, right, epithelium creates a what? A border, a boundary, a protective layer. So if we have damage to a tissue that has epithelium on it, you got to build it back up. Super important. I go over epithelium a lot because it's really important. It's one of our front lines of defense. Okay. Okay. Any questions about this? Is interesting. Melanocytes cannot. Do you know what melanocytes? Remember what melanocytes are?
It's the skin.
It's in the skin. They're in the bottom layer of the skin, and they produce melanin or the coloration to our skin. So they can't regenerate. If you get a cut that's deep enough, you won't have melanocytes in that area, and that contributes partially to what? The scar being lighter. I thought that was kind of cool. Yeah, isn't that cool?
Is that why it's like?
Well, in the beginning, it'll be pinkish because of granulation tissue, and then over time, usually it turns more whitish. Don't you think?
I'm just thinking of my son thinking I had open heart surgery. He's had it so often, but gosh, that's been like 3 or 4 years ago. And it's so raised. Maybe it's like got that. What is it?
It got like a keloid formation.
Probably.
Yeah. Yeah, it
It's
could be.
still, like,
But also, are they using the same suture line, would you call it, I guess, over and over again?
Yeah.
That's
So
probably,
scar tissue
yeah,
and stuff, right?
yeah,
Okay.
yeah. I would think that reopening of it is keeping it a little bit more irritated. Okay, so secondary healing, we talked about if the edges are not close enough to be brought together by itself, okay? You would need sutures or obviously wouldn't heal correctly. And what is that? That kind of takes me a little bit off track. When surgeons follow those lines, the collagen lines, what is that called? There are certain ways that the collagen fibers in your dermis run. Okay, so if you're talking about, my grandmother had squamous cell carcinoma that she let go and go and go and go and go until it had spread in the dermis from here to here. And they had followed, oh, I can't think of the name of them.
Dermatomes?
No, dermatomes is a sensory innervation to the skin. It's a real simple name too.
Contour?
Hmm?
Like the contour?
It follows the collagen lines, the cleavage lines.
What is it?
Cleavage lines, I believe it's called. I have to double check. I think, yeah, not like, yeah. So cleavage lines are the way that these collagen fibers run, okay? So this just brings to mind that if you can't bring the edges of a wound together appropriately, it won't heal appropriately. And that's why if you have, I think, and I'm sure most of you think this too, an open wound, who should be suturing you closed? A plastic surgeon, because they are aware of these collagen lines and they will most appropriately bring the edges together to follow them. So my point is that my poor grandmother, God rest her soul, had, all the way from here to here, they had to open her and get the cancer out, which I don't think they got all of it, but that's a different story. And then they sutured her. She had sutures all the way along and she healed like a gem, because they had followed those collagen lines, I believe it's cleavage lines. Let me double check, okay? So.
You don't want the second year resident doing it? No? Okay.
If you have like a wet to dry dressing from a huge open wound, that you're not using sutures, and that's, how are you?
Oh, well, it's not gonna heal, right?
Right.
You're keeping the
But it
edges
eventually
apart.
does.
Right, on
So
the
you're-
underlying, yeah.
Right, so how are you, I guess I'm just trying to.
So, well, what's your question?
Well, we're talking about like the epithelials and all those cells depositing all of that part. So you're not talking at that level, and you're building from the bottom up with the wet to dry. What's being formed down there?
Well, eventually, those cells are gonna migrate down, along those lines. Because what happens with, and I'm conjecturing this because it's something I've never dealt with directly, what will happen with the epithelium is healing will happen from the bottom up, are you with me, of the underlying structures, but then the epithelium will actually creep in and keep continuing. So if you can imagine, this is the open area and it's exposed, the underlying layers will build up, but then what happens, so the epithelium is closely packed cells, right? But there's no closely packed cells, right? Because that overlying skin is gone. But what will happen is, if there's epithelium here, if this is the edge, they start to fill in, right? And, can you visualize that continuing without me filling? And they keep coming in and 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 in. And they don't know how far to go until, guess what? They meet. So is that answering your question? Is that what you were asking me? Are you with me? Are you thinking because there's no sutures? But it's not going to heal correctly. Right. It's not going to look like it did originally. Does that answer your question? Sort of, kind of? No? Yes? You sure? Okay. All right. So, in order for it to heal correctly and look as close as possible to the original, which in some cases it may not, right? You would have to bring the edges closer together. But that's a different example, right? Okay, this is talking about, your kid's out, they split their lip, they need suture kind of thing, right? I hope I didn't just jinx myself. Because guess what my son asked me for his birthday? A skateboard. Okay. So healing by second intention, where was I? Larger, potentially more debris that needs to be cleaned out, right? Could be wound contracture if it doesn't heal appropriately. It'll move towards the center. Need sutures, may not heal well. Okay, so any questions on that? That's pretty straightforward, right? Okay, so components of the healing process. So when you're looking at a tissue, you have what's called the parenchyma and the stroma. The way that I remember this is stroma is the structure. Okay, so you have kind of this network of like collagen fibers and reticular fibers. And the stroma is actually what they're starting to use as a template to create new organs for people. It's really cool. I have a neat little video that we're going to watch. I hope it's in here. So they'll take that person's tissue and actually create the structure or no, I'm sorry, they'll take an artificial stroma, and then they'll take that patient's cells and they can embed it in the stroma, and it's starting to replicate and fill in. It's really cool. Okay, so parenchyma is going to be the functional cells, stroma is the structure, the supporting fibers, extracellular matrix, etc. Okay, so regeneration versus repair. What's going to be the difference between regeneration and repair? Yeah, right. Which is going to be scar tissue? Repair. Yeah. So some tissues can regenerate. Give me an example of a tissue that can regenerate. Liver, right? To a point, right? Skin, absolutely. And who can't regenerate? Brain, heart, right? Okay. Certain parts of the kidney, right? Can't regenerate. Okay. So, and also here's a big one, blood supply, right? Think about the different types of tissues. Is bone able to regenerate well? Yeah, right? We slap a cast on it. We approximate the ends if they're not approximated, either surgically or manually, and it heals, right? How about cartilage? Anybody ever blown a meniscus? Did that heal itself? No, what's going to heal it? Surgery, right? Why? What's the difference? Why is bone healing and cartilage isn't? Bone has a big, huge blood supply. Okay, so some tissues have regenerative capabilities inherently because of the cells that make them up. Some have blood supply, some don't. Okay, so those are two big things that'll help us differentiate what's regenerative versus what's going to create repaired scar tissue. Okay, neutrophils are going to be the front line. They're going to be the first cells that show up. They're going to fight off bacteria. Then macrophages show up later, which kind of makes sense, right? Because the macrophages do what? They eat up substances, but they also clear the way. And there's the little brother, the fibroblast, behind depositing those collagen fibers, reticular fibers, whatnot. Okay, so components of the healing process. So regeneration, do we remember mitosis? Should I go through all the phases of mitosis? I'm totally kidding. Yes. So mitosis, to sum it up in a one-sentence definition, would be the ability for a cell to divide. Okay? The ability of a cell to divide. And when that cell divides, don't forget it's going to create an exact replica. Okay? It's going to create an exact replica. So I go back to my skin, I rub my skin, lots of skin cells are falling off. At the bottom of that layer of epithelium, there are cells replicating and pushing up new skin cells. Okay, they're highly mitotic. If I were to go, I don't want to say it, and cut my brainstem, that is not mitotic. That is not going to heal itself and replicate. Okay, somebody dropped the ball somewhere. With that, right? Okay, so degrees of regeneration, labile is going to be constantly regenerative, such as the skin. Okay, stable will regenerate in periods of need. The liver is a great example of this, right? The liver is pretty regenerative if there is damage to it, but it's only regenerative to a point, right? We could only drink so much alcohol until it gets really fatty and turns into scar tissue. So it has the ability to replicate, okay? Permanent lose their mitotic ability usually at birth, okay? Excuse me, heart, brain, okay? Nerves, okay? Are we good with all those different? Okay, I'm gonna stop talking for 5 minutes. I want you guys to answer these questions at the bottom, okay? I get to take a breather. People at home, I'm going to zoom in so you can see the questions. Pretend you're in class and answer them, and then we'll review them. Would there be more answers theoretically? Yeah. So what I want you to do is think about your answers and try to use the words, right? Try to use labile, stable. I almost said stable. Stable and permanent. You know, use the words. Try to get them into your head a little bit.
Oh, so scar tissue.
Oh, I want you to use these 3 words.
Okay.
You don't
So
just
it's
to use
always
them.
gonna fall into one of these 3 versus saying it's scar tissue or.
Well, you can create scar tissue in the liver, even though it's has stable regenerative capabilities, but that tissue inherently is still stable tissue. It has a moderate amount of ability to regenerate.
Okay.
Okay? So it wouldn't turn into permanent tissue. You see what I'm saying?
Yep.
Is that what you were asking, I think? Excuse me. Oh, what a nice video. Are we done? Yeah? Okay. I'll just grab a rough drop. Okay, so first one. So with a myocardial infarction, what type of tissue? Permanent. And will it regenerate? No. So you actually form scar tissue. Are people able to be rehabilitated though? Yeah, because what happens? Can create a new blood supply. But is it going to matter if there's scar tissue in that area? No, but what can happen? Other what?
Parts will compensate.
Other parts will compensate. So the cells around that scar tissue can get bigger, right? Your heart can hypertrophy. Have you ever heard that? People who are athletes are able to do what? Pump the heart less often because their heart's hypertrophy and get a little bit bigger. So per pump, they're able to pump more, right? So the surrounding cells can actually expand and get bigger and help out, okay? But the actual tissue itself is not regenerative, right? With second-degree burn, what type of tissue is damaged? Labile, right? And is it regenerative? Absolutely, right? Absolutely, okay? With a stroke, what type of tissue is damaged? Permanent. Will it regenerate? No. Hopefully there can be compensatory mechanisms, right? Okay, some people are able to compensate. And it also depends on how long they have the clot for, right? If they've gotten rid of it, I believe there's a 7-hour window where if you get the TPA administered, okay. So it depends, But in general, looking at it theoretically, just trying to get those ideas in your head. Good. Any questions on anything so far? Oh, okay. Good, repair. So repair is going to be the formation of basically scar tissue, okay? So fibrous connective tissue will replace that original tissue. Scar is basically very collagen rich, okay? From those fibroblasts, we've kind of gone over all this. Fibrinogen is turned into fibrin in the initial phases to form a clot. Now this is kind of interesting, and I think we've actually gone over this. Why don't more people throw clots then? Yeah. What breaks it down? Why don't we throw more clots? I threw out there. And then she said when her body is done with it, so in that localized area, that capillary is torn open, you know, just for an example. We've formed a little clot. Your body knows now to break that clot down. And it breaks it down with, remember? Plasmin, right? We have plasminogen, which will be converted into plasma, and it'll break that clot down. So your body's constantly doing this, right? Constantly doing this so we don't throw clots. Sometimes it goes awry though, right? And we do, but hopefully not. Okay, so, oh, there it is right there. I always ask the questions and I give the answers. So plasminogen will be converted into plasma, it'll break the clot down. And then here are little phagocytes again, eating up those substances.
So people with history of clots and like family members with history of clots, brothers and stuff like that, is that because they're lacking something?
There's probably something in that clotting cascade that'll facilitate it more quickly. Yeah, I have a patient who's on like triple the dose of warfarin, and it's just how he is. His doctor literally has to call. It's triple or quadruple, literally. His doctor has to call every time he gets it because the pharmacist gets it every time and is like, really? But some people are just more prone to that. And I think it's genetic. You know. I mean, there are certain cancers that could cause, you know, an increase in the platelets, but you know, there are some people who are just prone to it. Yeah. Okay, so repair. Good. Revascularization is going to be the creation of new blood vessels, also known as angiogenesis. It's kind of cool how it happens. Your book sort of has a good picture. I know this book is not the best, but what are you going to do? It's the best that I could find without
It's way
killing you.
better than other I mean,
Huh?
It's easier reading than other pathophysiology.
I really think it is. Reading the other pathophysiology courses really needs to be a 2 or a 3 semester class, you know, because it brings it into such a depth. So, anywho. Okay, so where was I going? What was I doing? Oh, revascularization. So if this is a tissue that's been damaged, surrounding blood vessels that are still intact will actually start to send these little buds out. And those buds just keep growing, you know, and growing. And then the blood vessel on the other side is doing the same thing, you know, and it'll keep growing until eventually they anastomose, where they meet, okay, and they'll start to reestablish the blood supply in that area. Pretty easy little concept, really. Okay. So over time, those blood vessels, this was kind of a weird description in your book. I don't think there's quite as many blood vessels in scars as there is in normal healthy tissue. So they have that whitish, more white kind of appearance. Okay, so revascularization. Okay, surface restoration, this is what we talked about when we talked about those epithelial cells growing back in. Now the thing about that is that they will fill in, it's really kind of cool. The cells themselves, you know, that normal like round shaped cell will actually send out little feelers and then keep going and replicating, right, and filling it in. And in normal cells, they will eventually touch and they stop replicating. Is this on here? Yeah, they stop replicating, okay? In cells that have sort of gone awry, their genetics have gone awry, they lose this ability. And this ability is known as contact inhibition, okay? Not in front, there we go. Contact inhibition. In normal cells, when they fill that space, they stop replicating. In cells that lose that contact inhibition, they lose that ability to sense that and they keep replicating. Well, doesn't that make sense? Because what does cancer do? Keeps replicating. Okay, it's lost that, it's one of the huge things that they study with cancer. They've lost that contact inhibition and they keep replicating. Okay, they don't get turned off. Okay, so with that surface restoration in normal healing, they'll touch and then they'll stop replicating and fill in that space. Okay. So major tissues, healing. Okay, so connective tissue. So grouping these together, if you watch the tissue lecture, okay, so connective tissues. So bone is going to heal really well, right? Because it has a nice blood supply. Now, it depends on how the bone is fixed, though. Have you ever seen that false pseudo joint? Okay, when bones are not, and my ICU people or people that deal with trauma, right? Well, maybe you wouldn't see this because it's more of a long-term problem. My cousin fractured his clavicle. Well, it's one of the worst bones to fracture because you have a whole bunch of muscles that attach to it, and it's pretty stressed because if you think for a second, your clavicle, guys, is the only bone that attaches to your axial skeleton of the shoulder girdle. right? It attaches here. It attaches to the scapula. The scapula is just floating back here, held by muscles. So your clavicle has worked a lot, okay? Are you with me? Are you with me? And it also has muscles that pull it up. So if you fracture your clavicle, it's difficult to keep it from doing this, right? Because it has muscles pulling on it. So his clavicle is healed like this with what's called a pseudojoint. It's very important to keep the bone in the proper position, or you can actually form a little bit of cartilage forms in it. It's like a little joint, and he gets popping and clicking in it. So you've got to have those bones approximated, or you're going to form that false joint. Okay, so it's important. But the problem with that is what major blood vessel is obviously underneath it. Clavin, thank you. So you can't tape it down, right? Because if you tape it down, it pushes the other way. Yeah, so it's kind of it's a bad bone to break. So you've got to approximate those ends to create that or prevent that from happening. And there's different steps that happen, you know, kind of the same thing. Clot forms, revascularization. Osteoblasts are going to be the cells in bone that establish new bone. Okay, osteoblasts. It starts off with this non-calcified, what's called osteoid. It's like a soft kind of matrix. And then we deposit calcium salts into it to make it hard. Okay? And then over time, that bone will be remodeled. It'll actually start a little bit thicker, and then it'll remodel over time to look pretty darn close to the original bone. So bones heal really, 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 really well, as long as they're put back together. Okay? Tendons and ligaments are not, right? Because what do they lack? They lack blood supply. They also don't have regenerative cells. So if you've ever seen somebody, I have a picture of, you ever seen somebody with a bicipital avulsion? It is the strangest looking thing. Is it dangerous? Absolutely not. Because you actually have two heads of your biceps, right? So you can kind of function without one of them. Usually it's one of those two heads that breaks off. And it's just like those old-fashioned shades, right? It just winds right up, and you can see a little extra bulge in that region. But it can happen in other places too. The Achilles tendon is a common one that can avulse off. Do we know what avulse means? You're pulling it, right? You're rupturing that muscle off the bone. It's pulling part of that bone off. But the tendon itself can also rip and tear, or ligament, okay? So those generally have to be surgically fixed if they're in an area that they need to be, right? Usually that bicipital tendon is kind of like, do you want it fixed or not, kind of thing, okay? Cartilage, same thing, is going to be a surgical fix. And once again, that's going to be to degree of damage. Okay, some people have meniscus that they can deal with for a long time. Some people it gets to be a real problem with. Okay, adipose, who cares about huge fat? It has a moderate degree of regenerative capability. What?
I think mine regenerate.
I think all of ours regenerate. Do you hear what they're doing now, though, with adipose? They're freezing it. Somehow they're freezing it, and it's like dying off. They're doing it in Syracuse, and one of my friends was.
Like that cool sculpting?
What is it called? Cool. What is it called? Sculpting. Yes. Yes. So that's like the newest thing.
Freezer for a while, I think, or
They wrap you.
They do what?
They wrap you.
They wrap you and freeze you?
I don't know what it is. I know they wrap you. Our friend of ours just got married and had it done before her
And did it work?
A little bit, but I don't know for how long. You know.
Was it mucho mondo expensive? Yeah, I'm sure. I don't know. But anyway,
She
so
didn't have parts of it because she did her arms and her.
I would love, anyway. Okay, to do my arms. Have you know, for those of us who have had kids, do you ever notice like after you have kids, your body goes like this? Like everything just like 23% goes. I know I'm tired, but anyway. So adipose actually has regenerative capabilities. It's highly vascular, okay? It is highly vascular. Because guys, think about it. Fat is our secondary storage form of energy. We need to be able to tap into it, to deposit to it, and to get from it. And I'm kind of joking about fat, but we really need fat, right? It's our secondary storage form of energy, which I just said. It also helps to cushion organs, okay? It also helps to keep us warm, okay? So it is regenerative, it is vascular. Okay. Epithelial tissues are very mitotic. So once again, epithelial tissues covering lining, skin, lining of GI tract, respiratory tract. It's an important barrier. Every one of those areas are important barriers. Okay. Epithelium also helps to subdivide our internal organs, right? Helps to keep our lungs from our heart. Okay, so epithelium is very important. Kind of think of it as the packaging, okay, the covering. Well, packaging really is loose connective tissue, the covering of all those structures. Okay. Glandular tissue is stable. We talked about liver, has some regenerative capabilities, okay, unless it's pushed too hard for too long. And that process gets a little funky for people who either have an excessively fatty diet or drink too much. They can get fat deposited into their liver to the point where if I were to go in and dissect that out, it would almost slip out of my fingers. It gets, have you heard the term fatty liver? That's what happens. And you also get these little pockets of fat in the liver. And if that continues over a prolonged period of time, the fat's going to turn into scar tissue. Okay, and you get what condition? Cirrhosis. Good.
So
Okay.
if you have fatty liver, you're saying if it's not cirrhosis, then it can regenerate?
Yeah, you can reverse that.
Okay.
Absolutely. Okay, so same part with the kidneys, okay? So the kidneys are regenerative except for the glomerulus. I think I mentioned that earlier. Okay, the glomerulus is a very funky little thing. Do you remember the glomerulus? It's the first part of the filtration, right, of a nephron. Well, we'll do that in the future. Okay. Exclusions are posterior pituitary. This is probably getting a little bit too far ahead, right? Don't worry about it. We'll kind of get into that. Well, do you remember pituitary? No? Remember the pituitary gland?
Sure.
Okay, let's just go over this because then if I ask a question, I want to be like, I didn't go over it. Remember the pituitary, okay? What does the pituitary do? Helps to regulate hormones, okay? It releases all sorts of different precursors or releasing hormones, okay? There's an anterior part, there's a posterior part. Are you with me? The posterior part is made up of nerve cells, okay? The posterior part is made up of nerve cells. It doesn't make hormone, it stores hormone. Okay, oxytocin and ADH, does that ring a bell? Yeah, okay. ADH is what? Anti-diuretic hormone, good. And oxytocin's the cuddle hormone that helps to facilitate contractions, right? Did you ever hear that? Oxytocin? High levels of oxytocin are released after sexual intercourse. It helps to promote that bonding with your partner. Oxytocin is also released to perpetuate uterine contractions, okay? Keeps that positive feedback loop going, okay? So that posterior pituitary being nervous tissue, if it were damaged, would it regenerate? No, if you were to have a pituitary tumor that affected it, would it regenerate? No, okay? So I do think that that's kind of important. I was gonna kind of buzz over that, but the adrenal medulla, and it's kind of weird. Okay, I'll watch your eyes and see if you gloss over, but stick with me for a second. When we conceive a baby, okay, sperm and egg unite, and we form this little ball of cells, right? Does that ring a bell? And then those cells just divide, and we form those 3 layers of tissues. Remember mesoderm, endoderm, ectoderm, does that ring a bell? And then everything is derived from those 3 tissues, okay? Sometimes parts of the body will drag one of those layers with it. Okay, so the ectoderm is primarily nervous tissue. Are you with me? Okay, so that nervous tissue can be drugged down when we're creating the adrenal glands to the adrenal medulla. Okay, so even though the outside of the adrenal gland is glandular, are you glossing, or is this making sense? Okay, we've drugged down some of those nervous cells to the adrenal medulla, and that adrenal medulla is actually made up of nervous tissue. Are you with me? No. Does that sort of kind of make sense? Just remember that the posterior pituitary And the adrenal medulla is made up of nervous tissue, or of nerve tissue. Let's just keep it at that for now. If you really want to know, come see me on the break, because it's actually like a 10-minute explanation. Okay?
Nerve tissue.
Nerve
is
tissue.
not-
It is not regenerative. I think it's extremely rare that you'd hear of damage to the adrenal medulla. I think that you might hear of damage from a pituitary tumor in the posterior pituitary, but I think that's actually more often in the anterior pituitary. But just to get the concept in your head, okay? So they're made up of nervous tissue. Does that make sense? That's what I want you to know. Okay, good. Glomerulonephritis. So what's happened here is that there's been some sort of damage. Could have been an antibody-antigen complex likes to deposit around the glomerulus, okay? Could be some sort of infection that is spread into the kidneys. And what's happened is it's formed scar tissue around the glomerulus, okay? Do you remember the glomerulus is actually like around the outside of the kidney? And when you form scar tissue around it, it'll actually pucker a little bit. Okay, it'll pucker a little bit. And if we zoom in, let me get my people at home zoomed in, and lady Laura, first time today, okay? See, this is a nice, smooth, red kidney. Can you see the little puckering, right? The little indentations on the other one. It looks so much better if you look at it on your own screen at home. Can you? Oh, you can see it though. Actually, turn around and look at that one. I think it looks better. You see how it's kind of like not as smooth, it's a little puckered in? Okay, glomerulonephritis, that's nice and smooth and even, and the one on the right side's puckered in, especially if you look at the kidney on the right. I think you could see those indentations. Okay, so glomerulonephritis would cause a permanent scarring around the glomerulus. Okay. Oh, this is really cool. Okay, let me upload this video.
What was all that? Was the scar tissue the white?
Oh, wait a second.
Whatever?
The scar tissue is inside. It's around the glomerulus. And so what it does is it kind of pulls the tissue of the kidney in a little bit, and it creates this lumpy, bumpy type of appearance. See this?
Oh, okay.
Right there? Okay, you with me? As opposed to, let me trace this one.
Okay.
I think you just can't see it as well on this. I think it'll be a little bit easier for you to see when you look at your own computer. Okay, where was I? Here. So talking about that stroma and the parenchyma. The stroma is the structure. The parenchyma is going to be the cells. Good. Hopefully this works, right? Here we go.
Behold a holy grail of medical research, a beating heart created by scientists in the University of Minnesota laboratory.
We really have the audacity to claim to build a functional organ from scratch, so to speak.
Researchers know it sounds like the work of Dr. Frankenstein,
We're willing to admit that it's a crazy idea.
but they say this crazy idea could one day save thousands of lives because there aren't nearly enough hearts for everyone who needs a transplant.
3,000 people a year don't have other options. We want to make a difference.
So researchers started with the dead heart of a rat and using a detergent washed away all of its cells. All that was left was a gelatin-like framework. Scientists took that framework and injected new heart cells from newborn rats back into it. Within a week, the heart was beating and pumping once again.
It's exciting. Yeah, it's exciting.
While a rat heart can't help humans, a pig heart can.
Because it looks like a human heart, it acts like a human heart.
So the goal is to take a pig heart framework like this one, inject a potential transplant recipient's own stem cells into it, and grow a heart that matches the recipient's body, eliminating the need for anti-rejection drugs.
What we've done is hopefully open a door to the idea that we can actually begin to build not just pieces of tissue and organs, but build organs.
All sorts of organs.
This is a pig liver.
U of M researchers believe they'll one day be able to create new livers, pancreas, kidneys, lungs, saving not just thousands, but millions of lives.
It's really been science fiction in the past, and we'd like to think that we've helped make it science.
Isn't that amazing?
Is that from this year?
That, I don't remember because I saw it, like, I don't know when I saw it. And I searched for the video because that was what I actually saw in a video. It's amazing because if you watch the immune lecture, our cells have proteins on the surface of them that mark those cells as ours, right? So if I were to give you my tissue and we were not compatible, you would reject it. Well, this washes away those cells, right? And then you take your own cells and you put it on. It's amazing. It's pretty cool. So that's pretty awesome. So you have the link in your lecture if you want to watch it again. Okay, so from current slide. Okay, so nervous tissue. Remember the whole basic structure of nervous tissue? There is, do you need a cough drop? No? Okay, don't cry, it's not that bad. I'm just kidding. Remember the different parts of a nerve cell? There's the body, and what's in the body? The nucleus. Let's back our people out from home. Okay, so we've got the basic structure. I think we already went over this too. So we've got the body with the nucleus. We've got the process that sends information out is the axon, and usually there's multiple of these that receive information in are called the dendrites. Okay, we remember that general structure, right? We're going to get more into it. Okay, so the three basic parts of the nerve cell. Now, around those nerve cells are what are called neuroglia. That's a generalized term for supporting cells. Okay, neuroglia are going to be supporting cells. So they feed them, they nourish them, they help to insulate them. Okay, neuroglia. Okay. Now, let me back this out. If we have damage to a peripheral nerve, can it be repaired? Can it be fixed? Yeah. So like if I work with my hands a lot and I use a knife and I cut my carpal nerve, okay, that goes into my hand, that can be repaired, okay? If I have damage to my brain, my spinal cord, can that be repaired? No. Okay, here's why. There are different supporting cells. In the central nervous system, the cells that create the fatty sheath around nerves, do you remember that? Okay. You don't need to know the name. They're called oligodendrocytes. Okay. Those oligodendrocytes are not team players. If you have damage in the central nervous system, they will not come in and fix those nerves. In the peripheral nervous system, we have supporting cells called Schwann cells. That name I do want you to know because it's one of the names of cells that are kind of involved in research. Those Schwann cells create the fatty sheath or the myelin sheath that goes around the axons in nerves. Okay? The Schwann cells, guys, are team players. If we have a damage to a nerve in the peripheral nervous system, so anything outside the spinal cord, okay, in a generalized term, anything outside the spinal cord, if it is damaged, if it is pulled apart, if it is cut, if the ends are put together, those Schwann cells will move in and create a fatty tube through which the ends of the nerve will find each other. It's really cool, okay? But here's the thing, they've got to be relatively close, okay? They've got to be close and it's got to be surgically repaired quickly. If the ends are too far apart or the ends stay really far apart for a long period of time, the part that is away from the body will die. Okay, so there's only a certain time, I don't know what the exact time frame is, but my point is the Schwann cells are the supporting cells in the peripheral nervous system. They'll create a little fatty tube, okay? As long as those nerve ends are close, they'll actually send little shoots, the nerve cell, and it'll repair. Does it create new nerve cells? No, it doesn't. But it can repair, as opposed to the central nervous system. So what they're doing, why I want you to know about Schwann cells, is because they're they've probably been doing it for years. They're trying to take those Schwann cells and do what with them? Put them in the central nervous system. Yeah, brain, spinal cord, right? And try to know more for repairing. If somebody's had, like a severe neck trauma, right? And try to repair the central nervous system, which is kind of cool, okay? Kind of a cool thing. So you can, if the nerve doesn't heal right, you can form what's called a neuroma. Okay, so this is kind of a good bread and butter term, right? Tangled kind of mess of the ends of the nerve and scar tissue. Where do we hear this? Actually, I have an example. I have a picture. Hands and feet is a big one, right? We can get Morton's neuroma. Okay, I put this. I'm not going to read it to you. You can read it on your own because it's all kind of, clinical stuff. So Morton's neuroma is going to be on the ball of the foot. Okay, it's going to be on the ball of the foot. And I actually think they approach it from the top of the foot. We'll see in just a second. And you can get this neuroma. I had a friend who had this, and he was a big runner. It's probably what precipitated it. Probably damaged that nerve, okay, in the foot. And it created a little bit of scar tissue in that area. And it's pretty uncomfortable to walk on. But the surgeries vary. Has anybody ever had the surgery for it? Lady Laura, can you hit the lights, please? Okay. So they actually go in and they'll try to clean that up and clean it out. And from what I understand, it's very, very painful because they're fiddling with a nerve, right? The other thing that surgeons amaze me with their clinical prowess because they'll go in and there's, the bone in the foot and the nerves and a lot of fat. And they'll go in and they'll fix that. It's just amazing to me how they do it.
That's
so
the top of the foot, though, right?
They go in, that's what I was just saying, they go in through the top of the foot, okay? Because you can see there's the hair. Hopefully that's the top of the foot, right?
Very bottom.
So, hopefully. Okay. Okay, muscle tissue. So skeletal and cardiac muscle we know is not regenerative. Yes?
I have a question about,
Sure.
like, if the nerves are damaged due to pressure, swelling pressure.
Like carpal tunnel.
Yeah. Would that be, if they did roach and things like that, and the pressure was reduced, it wouldn't have to find itself again.
No,
the other end.
but if you put pressure on a nerve for a prolonged period of time, it will actually decrease its ability to conduct action potentials.
Okay.
And usually what will happen is the first thing that'll go will be sensory.
Okay.
So if there's a
the numbness
prolonged
to-
period, exactly, that'll usually be maintained. So, and then if the pressure gets to be even harder, it can affect muscular function as well. So it depends on how long that nerve is compressed for.
So generally, if you are at the point where there was paresthesias down the
Like you're
fingers,
just starting to feel it,
then it wouldn't necessarily get better over time, right?
without treatment,
Right.
every case is individual.
Okay.
So if you're, is this a personal question? If
No.
you're, okay, because if you are having paresthesias for a prolonged period of time, you should absolutely get them checked. Because if you keep putting pressure, so if you do get carpal tunnel, which is going to be median nerve into what fingers? Paresthesias into what fingers? Thank you. Because I've seen people operated on these fingers. Okay, so yeah.
Okay.
Yeah, okay, which is a whole different, yeah. Anyway, I think it was only once. I was like, oh. Like, what do you say? I still have numbness. Yep. Because it's your ulnar nerve.
You didn't intervene there either, huh?
What?
You didn't intervene on that one either.
I didn't, no. Are you going to turn me in? No, I actually told them it was wrong. I did tell them. So anyway, where was I going? So carpal tunnel, compression on the carpal nerve, right? So where am I going with that? If that continues over time and that pressure continues, you can get persistent paresthesias. You can also get a hypothenar atrophy, which is going to be a wearing away of that muscle. Okay, so thenar atrophy. thinner atrophy. Okay, so yes, it can be permanent, but every case is going to be different, and it depends on how long it's compressed for, and also the degree. It could be compressed just a little bit, causing a little bit of paresthesia. That could, go or be limped along for a longer time. But if there's a pretty good amount of pressure, you want to get that off. So, okay. So, skeletal and cardiac muscles, we went over this, repaired with fibrous tissue. Surrounding muscles can grow in size and help. Skeletal muscle has a little bit of regenerative capability, not a whole bunch, okay? Smooth muscle can divide, okay? We talked about this a couple weeks back as well, right? The uterus is made up of smooth muscle, and that can divide when a woman gets pregnant, okay? Kind of cool little thing. Okay, so bicipital brachii avulsion. So, and this avulsion is exactly how it looks. What I found kind of interesting with this picture is it shows it from the distal aspect, but every time I've seen it, it has been one of the two proximal heads. Because if one avulses, well, one's intact, and they usually can function pretty well. Okay, so bicipital brachii avulsion. It's going to be a breaking of that tendon. You can also, well, I've got this picture up here. So you can have the tendon break, but you can also have a little chunk of the bone come off with it. Okay, so never fun. Never fun. So complications of healing. Let's do, how much more do we have to do? Like, hold on. Do you want to just push through and we'll get out a little early?
Yeah.
Yes, no, or do you need a break?
Yeah.
No, let's keep going, right? Because the rest, it's not real heavy stuff. So it's probably a lot of stuff that seems a little familiar. Okay, contracture is going to be a shortening of the tissue due to an extra deposition of collagen. Okay, so what's happened is there's been an overuse or something's happened that has damaged that tissue, and the body's response is to deposit extra scar tissue in there. Okay, and you get what's called a contracture. I have pictures, I have little examples of this. Okay, I think I have it in a tendon, but you can also get this in the skin as well. We would see this post what if somebody's in a fire, right? You can have contracture of the skin if it's not healed or taken care of properly. Okay. Stricture may occur in lumens of organs causing stasis, which is what? Lack of movement, right, of substances, and can eventually lead to necrosis. Okay. Adhesions. So when, remember serous membranes are going to cover, primarily the ones we're going to be involved with are going to be around the lungs, around the heart, around the abdominal organs. If you get some sort of infection, a peritonitis, a pleuritis, a pericarditis, you can get adhesions between those serous membranes. And the thing to keep in mind is those serous membranes are double layer, right? And when they are normal and healthy, they release a little bit of serous fluid, which decreases friction. When they get infected, you get what? A little bit of adhesions, which is that fibrous kind of scar tissue forming between them. Okay, so adhesions can restrict the movement of the tissues a little bit. Okay, dehiscence, is that how you say it? Dehiscence. Okay, breaking open of a healing wound. I swear, it's like God sends me little signals. I was preparing this lecture and I was sitting in Peter's Cornucopia and an old friend walked up and her husband, what did he have? Oh, he had an umbilical hernia repair, and guess what had happened? He coughed, yeah, or sneezed maybe, well, whatever. Coughed or sneezed, and it popped back out. And he was like, do you think that's a problem? I'm like,
He showed you?
well, no, he just asked me. And I was like, well, yeah, you need to, yeah. So anyway, and this obviously would be, that increase in that intra-abdominal pressure, okay. One thing on here, I'm kind of buzzing through, this is all familiar, right? Okay, kind of buzzing through it. I do want to talk to you about a pathophysiological basic thing, okay? 2 important substances for healing. There are multiple important substances for healing. So let's say 3, the top 3, okay? Protein, okay? Protein. Because protein creates what? All the structures of the body, okay? So protein. Vitamin C is very important in the formation of collagen, okay? Vitamin C is very important in the formation of collagen. And zinc. Zinc is very important in the ability of tissues to regenerate and heal themselves. So just as a little side note, if you know somebody who's healing from a trauma, okay, those are going to be 3 important things. So obviously a healthy diet, but also a good amount of vitamin C, a good amount of zinc, even a little extra, right? The only negative side effect with taking high levels of vitamin C is, I mean, you know what the side effect is? It's not dangerous, but it's nasty. Yeah, it's acidic diarrhea. Okay, so high levels of vitamin C when somebody's healing. Never fun, but not life-threatening. Okay.
Zinc too, they only recommend zinc for a period of time because
Yes, zinc is.
I had
Yes.
a new resident from UCP and pharmacy did her chart audit.
God bless you.
and Documented that Dr. Ryan needed to DC the zinc because she'd been on it for years.
Oh, yeah. No, zinc I would not recommend at high levels. That would only recommend in the daily, regular, you know, RDA. So.
What happens with too much zinc?
It didn't really say, I don't know what.
I think it can cause deposition into tissues of the body, I think. Yeah. No, I don't think it's a real dangerous one, though. It's not like vitamin A. You know, vitamin A at high levels is toxic. I think it's just like not good to take for a prolonged. I think it's something with the GI system. Okay. So, okay. Keloids, irregular masses of scar tissue. This is going to be people who, when they get some sort of injury, overproduce that scar tissue. Okay, that's what happens with keloids. Okay, they overproduce that scar tissue. So if they get a cut, rather than having a nice little scar that heals, they'll have a little extra, you know, chunk of tissue that's built up there. Okay. Now, keloids is different from proud flesh. Proud flesh is going to be granulation, persistent granulation tissue. Now, granulation tissue we did actually go over, so let me refresh your memory. Granulation tissue is in that spectrum of healing. It's going to be when the tissue gets revascularized, okay, but it doesn't have that epithelium covering it yet, okay? So what does it look like? It looks pink, okay? So overproduction of granular tissue or granulation tissue.
Not good, or?
No, because it's not completing the healing process, right? It's staying at that immature process where there's little capillaries and you're not covering it with that epithelium yet.
What causes that?
Like an infection that's gotten into a tissue that's not letting it heal. Like there's, well, and I'll show you a picture in just a second. Okay. Something that's inhibiting it from healing, most likely an infection. Okay. Suture complications, that makes sense, right? Okay. Scarring, post-surgical, if somebody doesn't know how to suture properly, right? Okay. Always opt for the plastic surgeon. Okay, so Light Lady Laura, if you could hit the lights for me, thank you. And I'll zoom in for my people at home. Okay, so take a minute. What complication out of those that we just reviewed has occurred? These should be pretty easy, right? This is why I wanted to forge ahead and just finish up. What could this be? Contracture. In what? Uh-huh.
Right, isn't that what you're saying?
I think you said it. In the tendons, okay? The tendons that go down to the toes actually start in the front of the shin, okay? And they'll go down, some of them start in the top of the foot, right? So those tendons on the top of the foot that help the toes come up have gotten contracture. They've gotten an excessive scar tissue. So probably some sort of trauma, I would guess, has happened to this patient of some sort that's caused scar tissue and that causing that contracture. This is interesting. Is a description up here? I'll give you a minute to look at that. Can you see this? What do you think this is? It could really be two, right? Two things. Can you see what it is? You see that's the belly button,
Yeah.
right? Okay, all right. So So without thinking about it clinically, which is funny because this is the opposite direction I normally teach, without thinking about it clinically, which of these complications that we've gone over would this be? Could be two, right? What do we think? Yeah, absolutely. Absolute dehiscence, right? And it could be, oh,
Are you saying?
it could be. It could be adhesions as well. What'd you say?
Oh, I'm just talking about there's a scar line, so it could be a dehisc.
Right? And it is. And it could also be a scar complication, right? Or a suture complication, right? Is what I mean. Not a scar complication. So this is interesting. So I left the description up there for you. This is a woman who obviously had, either surgery or, had her, I can't believe out of all this, C-section. I can memorize like all these really long words, but then I lose common from, or C-section, right? And this is part of the endometrial tissue that snuck out. You know what the funkiest part is? Is that it would bleed every month with her period. Now, once again, I'm guessing maybe this is somewhere that she couldn't get health care, because what a complication to have. It also shows the persistence of endometrial tissue. Okay, it's endometrial tissue is formidable. It'll, if you are prone to endometriosis, will go outside the uterus, on the outside of the uterus, into the abdominal cavity. I mean, it'll just go everywhere, and then guess what it does? It forms scar tissue, and it is persistent. Okay, so this could be adhesions, this could be dehiscence, this could be a suture complication. Either one of those would be fine. Well, it's not fine, poor honey, but okay. So what would this may be hard for you guys to see because the color gets a little blanched out, but we're looking at this right here. Okay, this is actually the neck, right? We're looking at the opening for a trach. Okay. It actually is pink. For some reason, it's getting blanched out on this. If you, once again, this, I don't know, there's something wrong with the projector. Yeah, this is definitely proud flesh because the answer is right at the top. But other than that, when you look at it on your screen at home, I think you'll see a difference. And it has that kind of shiny. Do you ever, we all do it, especially when we're young. What happens when you get a scab? You pick it, right? And if you pick it too early, you get that real shiny flesh underneath that looks a little pinkish, and you could almost see the little capillaries. Can you guys sort of see it up there? Can you guys see it up there any better? Not as much, right? Maybe a little bit. So, excuse me, that's really what it would even look like, and it looks a little bit better on the TVs, on your laptop screen, on your computer screen. Okay, and you lose that epithelium on top, okay? So you don't have that nice kind of skin layer, okay? What complication would this be? Yeah, this is gonna be underside of the liver, I believe. And here we go, Fitzhugh-Curtis syndrome. Do you guys deal with that a lot? Yes, no? Violin string adhesions. Okay. So pelvic inflammatory disease, once again, also formidable infection, okay, can spread up and out the fallopian tubes and into the abdominal cavity. And it can actually go underneath, okay, into the peritoneal cavity. I believe it's the connection between the liver, well, there's not a connection. It causes these adhesions between the liver and the diaphragm, okay. So, yeah, can really create adhesions anywhere though, right? Once it gets into the peritoneal cavity. Okay. Yeah, that was easy, right? Keloid, absolutely. Okay. And this would be either, dehiscence or also the suture complication. I think either or. Okay, good. So, therapy that interferes with healing. Thank you. So, anti-cancer, anti-inflammatory corticosteroids, I think, because it's going to, all of those are going to help to decrease, some of that immune response. Okay, so it can decrease the ability to heal. Requirements for healing, we talked about nutrition. Copper you can throw in there as well. But I think protein, vitamin C, and zinc are really the big guys. Blood supply, obviously, we talked about that. Immobilize, depending on the injury, right? Okay, depending on the injury, you need to immobilize that patient, clearing out the debris and kind of going backwards, aren't I? But I feel like we've gone over most of this, and it varies according to the tissues, the requirements for healing. Okay, so this talks about that contact inhibition, because we have growth factors, and there's a whole list of them in your book. I just want you to understand the concept in general. Growth factors will produce the ability for cells to replicate. Okay, growth inhibitors tell them, okay, you're done. Okay, and there's got to be that good balance between them. There's got to be that good balance between them. If it gets too out of control and you don't have the growth inhibitors, well, you could get sort of that cancerous or that tumor presentation, right? Okay, so growth factors, growth inhibitors, the extracellular matrix sort of provides a little bit of an important aspect of whether a tissue can heal or not. You've got to have that gel in which all these things can exist to regenerate, okay, and heal the tissues. And then contact inhibition. And I like this picture up here. Let me back out for my people at home. I like this picture because it'll show, and this is exactly if you were to put cells into a petri dish that have the appropriate contact inhibition, they'll fill one layer of that petri dish, right, and then stop. And if you were to put cancerous cells in it, and let me tell you, cancer's formidable. Mamma mia, it's unbelievable. If you were to put cancerous cells into a petri dish, well, you could see they're not going to fill that layer. They're going to fill that layer, and they're going to start to grow up and keep growing and growing and growing. Okay, they've lost that contact inhibition. Okay, so you get out early today. Thank you. Let me go stop the tape recording.